Ladies and gentlemen, I warmly welcome you back to the 10th Symposium, and this symposium is themed on pleural effusions. Today we have some dignified dignitaries who are going to enlighten us with some insightful and knowledgeable cutting-edge information regarding this topic. This session will be chaired by Professor Dushanta Madagedara, Consultant Respiratory Physician at the National Hospital Kandy, and is also a chair professor at the University of Wyoming. Also, he will be supported by Dr. Alpha Sadikin, Consultant Respiratory Physician at the Colombo South Teaching Hospital. Dear sir, the stage is yours.
Good morning. First of all, I'd like to welcome all of you for this plural symposium, Symposium 10, organized by Sri Lanka College of Pulmonologists. On behalf of the college and my co-chair, I first of all like to thank all our 4 speakers, 3 from the overseas. They are very good friends of Sri Lanka College of Pulmonologists, helping us to organize the webinars as well as a symposia for last several years, as well as a workshop. And our local speaker is a good friend of ours and a member of Sri Lanka College of Pulmonologists. And this symposia is focused on very important practical aspects, on the different aspects of the pleural disease. Without taking much time, I'd like to start with the symposia to the first speaker talking on the management of refractory transsudate effusion. It's a very important clinical aspect all of us face in day-to-day practice. It's going to be presented by Dr. Anand Devanagam from Singapore, the Senior Consultant Respiratory and the Critical Care Medicine, Singapore General Hospital, Singapore. Anandan, to you.
Sri Lanka College of Pulmonologists 2023. A big thanks to Ravani and Dushanta for the kind invitation. And I've looked at the program and it looks terrific. They've done an excellent job at putting together this Congress. Before I start on my lecture on refractory transudative pleural effusions, I want to remind everyone that these slides are available on Facebook at our Sing Health UK Lung Center Facebook page. All the slides from all our lectures are available at this page. So let's start with a case presentation. This is a 70-year-old Chinese male with a background of ischemic heart disease and depressed ejection fraction. He presents with a 2-week history of progressive dyspnea on exertion. What do we do? Right? I know the history is limited, but let's try. Should we do a physical exam, do a diagnostic pleural tap, do a serum NT-proBNP, or an echocardiogram? Well, I tell all my students when given these sort of options, typically the best choice is usually to do the physical exam, right? Patients who come in with signs of heart failure and who have a pleural effusion, typically the pleural effusion is due to the heart failure, and these patients don't always need to have a diagnostic tap. You can treat these patients, and if they don't make progress, then you can consider the tap. You can corroborate your physical examination with serum biomarkers such as NT-proBNP, and if it is elevated, that confirms the diagnosis of heart failure. If we did go ahead and do a pleural tap, we might get pleural biochemistry results that look like this. So if you apply Light's criteria, the astute among you will notice that the LDH pleural to serum ratio is 0.62, and the total protein pleural to serum ratio is 0.51. So both of them on 2 out of 3 markers of Light's criteria, this patient has a borderline exudate. And this is typical of patients who have these type of pleural effusions. So although the topic is about refractory transudates, many of these patients on Light's criteria may very well have an exudative picture. And this is because Light's criteria is very sensitive for diagnosing exudates, but it sometimes is not very specific. And in cases like this, especially when you have had prior diuresis, you can get what is known as pseudoexudates, where transudates are misclassified as exudates. And that is because in diuresis, the fluid elements from the effusion are removed faster than the protein or LDH elements. In such cases, you can use the albumin gradient. And if the albumin gradient is less than or equal to 1.2 grams per deciliter, it confirms that it is an exudate. And if it is greater than 1.2 grams per deciliter, it's suspected to be a transudate. So what is the value of classifying transudates and exudates? Well, typically, the main causes of transudates fall into three categories: heart failure, hepatic hydrothorax, and renal failure. This accounts for about 95% of transudates. So the differentials for transudates is quite small, while the differentials for exudates are quite large. There are some rare causes of transudates, and these include what is listed here. I'm not going to go through the list, but I like to highlight some conditions like pulmonary embolism and malignant effusions, which you would expect exudates in, but sometimes you can get transudates. In pulmonary embolism, they may be lung atelectasis and associated transudates. In malignant effusions, they may be early lymphatic or airway obstruction, which can cause transudates. I want to look further at the terminology. If you look at large case series of pleural effusions, you'll realize that for the three big causes of transudates, cardiac failure, hepatic failure, and renal failure, a large proportion of patients, about a third, actually have an exudative picture on Light's criteria. And in fact, a number of these patients also have unilateral pleural effusions. It is for this reason the transudate-exudate dichotomy doesn't always work, and some of the current reviews are actually using the term non-malignant pleural effusions for these patients, or benign pleural effusions. Of course, this term itself has problems because this includes parapneumonic effusions, which are outside the scope of what I'm talking about today. The next part of terminology that we should clarify is the term refractory or recurrent. And this essentially are effusions which are unresponsive to medications and treatment of the underlying medical problem. And these patients typically require invasive pleural procedures. And the significance of this is that these patients who have refractory, transudative, or non-malignant effusions have been shown to have a poor prognosis, sometimes worse than malignant pleural effusions. So let's now take a look at the broad categories of non-malignant pleural effusions. First, cardiac effusions. I'm sure it is not surprising that heart failure is the leading cause of pleural effusions. It is the commonest cause of transudative effusions, accounting for about 80% of cases. And in about 70% of heart failure will develop a pleural effusion somewhere in the course of the disease. Of course, how we detect these effusions, or what we use to detect these effusions, also determines the frequency of detecting the effusions. If you use physical examination, you will not pick up too many effusions. But if you use chest x-ray, and if you use a lateral chest x-ray, you'll pick up more effusions. And if you use bedside ultrasound, you'll pick up even more effusions. And if you do CT thorax on all these patients, you'll pick up a large number of effusions. What is the pathophysiology of pleural effusions in heart failure? This follows the rule of twos. There are two pleural surfaces, the visceral and parietal pleural surface, across which fluid can transudate. And relating to these pleural surfaces, there are two vascular pressures to note: the systemic pressure, or the systemic venous pressure, and the pulmonary venous pressure. So if you have left heart failure, you have raised pulmonary venous pressure, which will cause transudation across the visceral pleura. Whereas if you have right heart failure, you have raised systemic venous pressure, which will cause transudation across the parietal pleura. Besides the hydrostatic forces, there are also oncotic forces that can cause accumulation of pleural fluid. And this is due to the fact that many patients with transudative effusions typically have fluid overload and have electrolyte abnormalities and sodium retention. The question I'm often asked is, can pure right heart failure cause pleural effusion? And the answer, as I mentioned, is yes. And that is typically because, as I said, you can get raised systemic venous pressure and transudation across the parietal pleura. However, the most common cause of a large unilateral pleural effusion in a patient with pure right heart failure is actually translocation of ascitic fluid, ascites moving across the diaphragm from the abdomen into the pleural space. Now, if you look at what are the causes, if you ask, when should you tap effusions in patients with cardiac failure? As I mentioned before, you don't have to tap all of these effusions. If the clinical picture is consistent with heart failure, you can treat the patients first and wait for any clinical response. But you should consider tapping if the effusion is unilateral, if there's a big discrepancy in the size between bilateral effusions, if there's no evidence of cardiomegaly. If you do have evidence of fever, pleurisy, or suspicion of malignancy, the clinical index goes higher and you're more likely to tap. You will also consider drainage if the effusion is very large and the patient is very dyspneic, or if the heart failure improves and there's a big lag in the improvement of the effusion. As mentioned earlier, the transudate-exudate dichotomy based on Light's criteria does not help us very much, and we have looked for pleural biomarkers. One of them is pleural NT-proBNP, and there is systematic review evidence to suggest that a proBNP level of greater than 1,500 picograms per mil is strongly suggestive of a cardiac cause of the effusion. However, I'm sure many of us don't use the pleural NT-proBNP levels, and this is because of the strong correlation between the serum and pleural levels, which makes it unnecessary for us to measure the pleural levels. Another way to diagnose cardiac effusions is this scoring system. So this is for patients who have suspected cardiac effusion, but who have an exudate on Light's criteria. So using a scoring system of age, the albumin gradient, whether there are bilateral effusions in the chest X-ray, the pleural fluid lactate dehydrogenase, as well as the protein gradient, you can use a cutoff which has got a high specificity for cardiac effusions. There are cardiac effusions which are caused by more than ischemic heart disease and a poor ejection fraction. You can get transudates from mitral valve disease, from infiltrative cardiomyopathies such as amyloidosis and sarcoidosis. Constrictive pericarditis can cause both transudates and exudates. You can get exudates post-myocardial infarction or post-bypass surgery, and amiodarone-induced lung disease can cause an exudative effusion. Like all transudates, you manage the underlying cause, which is why it is important to make a confirmed diagnosis. You can optimize medical treatment with fluid management, diuresis, salt and fluid restriction, managing the afterload and preload. And typically, these effusions will resolve within 1 to 2 months. However, there are a portion of patients in whom the effusions persist and you should consider drainage in these patients. It is worth noting that many patients with cardiac disease typically are on dual antiplatelet agents. Some of them are on anticoagulant therapy as well, which may complicate the decision to do a pleural drainage. Let's now look at renal effusions, right? Renal effusions are not as common as cardiac effusions, but they still occur in up to 20% of patients on hemodialysis. And unlike cardiac effusions, this is a marker of severe disease, right? It can occur due to fluid overload, and there can often be concomitant heart failure. There may be overhydration from water and solute retention. Renal patients, especially patients with nephrotic syndrome, may lose protein and are hypoproteinemic. And you can get a high output cardiac failure from a shunt in a large AV fistula. There are still further causes of effusions in renal patients. Renal patients are relatively immunosuppressed and are at risk of pneumonia and subsequent paraneumonic effusion. Uremia can cause a necrotizing fibrinous pleural inflammation, which can give you a blood-stained lymphocytic exudate. And nephrotic syndrome patients lose proteins in their urine, including antithrombin 3 and protein S and C, and this can predispose them to pulmonary embolism. There is one further unique pleural effusion associated with peritoneal dialysis. This is called a sweet hydrothorax. Essentially what happens is peritoneal fluid translocates across the diaphragm. This typically occurs early on after the initiation of dialysis, and the diagnosis can be clinched by measuring the sugar level in the pleural fluid as well as in the dialysate, and they match. No other hydrothorax that I am aware of causes such elevated glucose levels. A more confirmatory test can be injecting radio-labeled fluid into the abdominal cavity via the peritoneal dialysis catheter. And on CT scanning, you can see translocation of the fluid as shown on this picture across the diaphragm into the pleural space. These patients may need peritoneal dialysis stopped. Some of them are converted to hemodialysis. If you need to persist with peritoneal dialysis, these patients may need the diaphragmatic defects repaired surgically, and in some cases, pleurodesis can be considered. The third big group of effusions I'm talking about are hepatic hydrothorax. There are a number of causes of hepatic hydrothorax or causal mechanisms of hepatic hydrothorax. This includes azygous venous hypertension due to collaterals between the portal and the azygous venous system. The more common cause of hepatic hydrothorax is translocation of acidic fluid across the diaphragm. You can get lymphatic leakage from a congested thoracic duct because of liver failure. And hypoalbuminemia has also been implicated as a possible cause of hepatic hydrothorax. However, the evidence for or correlation between albumin levels and development of hepatic hydrothorax is quite poor. How do we manage hepatic hydrothorax? Again, you manage the underlying disease, you do diuresis, you manage the sodium intake, you make sure the patient is properly given proper nutrition. We can treat the underlying portal hypertension with transjugular intrahepatic portosystemic shunts, but the risk of this is, of course, hepatic encephalopathy. And of course, as I said, treat the underlying disease, and this includes doing a liver transplant. Now, a large number of hepatic hydrothorax do not respond to medical therapy, and these patients may not be a candidate for liver transplant, or the organ may be unavailable at the point at which the patient presents. These patients typically are immune suppressed, so they are at high risk of infections. They can be thrombocytopenic because of splenic sequestration of platelets, and they are frequently coagulopathic because of the synthetic function of the liver. That means doing pleural procedures in these patients has a high risk of infections and hemothorax. And these infections can delay or even exclude patients from the treatment of underlying conditions such as liver transplantation, which means the need for aseptic technique is ever more critical. In addition, because these effusions can continue to drain for days and sometimes weeks, large volume drainage can cause nutritional and electrolyte derangement, and you can get low albumin levels from continuous drainage of albumin out from the pleural drain. The role of intravenous albumin replacement is unclear. We know of the use of albumin for paracentesis-induced circulatory dysfunction prevention when you do abdominal taps, but its role in pleural drainage has not been proven yet. In addition, because the drainage of fluid continues on and on and on, it is very difficult to keep the pleural space dry, and hence the success of pleurodesis is somewhat limited. Now, having gone through the three main causes of cardiac effusions, renal effusions, and hepatic hydrothorax, the important point to emphasize is that we need to identify the underlying pathology and treat it. And in some cases, the patients may have dual pathology and both pathologies need to be treated. So coming back to our case, as I mentioned, a 70-year-old man with ischemic heart disease and depressed ejection fraction, and presenting with 2 weeks of exertional dyspnea. He has a transudate on the albumin gradient, elevated serum NT-proBNP, and a cardiac effusion is suspected. He has diuresis, fluid restriction, and treatment of the underlying heart failure, but has persistent dyspnea. And the question to all of you is, what do we do next? Would we do a therapeutic thoracentesis? Would we do pleurodesis? Would we insert an indwelling pleural catheter or palliate the patient with opiates? So here I come to the management of non-malignant pleural effusions beyond treating the underlying cause, which is the cornerstone, right? And all of these options can be considered. Therapeutic thoracentesis these days is typically done under ultrasound guidance. It is relatively simple to do and relatively non-invasive. The only problem is that the effusion tends to recur and you may need to do repeated procedures. And this is in the context of a patient which may be on antiplatelet drugs, which may be coagulopathic and who may be quite dyspneic. When we do thoracentesis, we need to ask 3 questions. Do the symptoms improve? If not, there may be another cause for the dyspnea. How fast does the effusion recur? And when the effusion is removed, does the lung re-expand? And these days, you can do this together with pleural manometry to identify the 3 classical curves to see if the lung is trapped. There are also newer thoracentesis needles, as well as digital pleural manometry systems, which allow you to identify the point at which the pleural elastin changes to identify entrapped lung by removing lesser amounts of pleural fluid. The other alternative is to do TALP pleurodesis. This is how we do TALP pleurodesis under thoracoscopic guidance using TALP poudrage. It's a little bit old-fashioned, but as you can see, we can get good coverage of the visceral pleura through this technique. The problem with doing TALP pleurodesis in non-malignant pleural effusions is whether or not you can keep the pleural space dry enough in order for pleurodesis to work. Now, of course, it goes without saying that you need to have lung re-expansion and apposition of the visceral and pleural pleura in order to have effective pleurodesis. And then in 2017, indwelling pleural catheters received FDA clearance for their use in refractory non-malignant pleural effusions. There have been since systematic reviews to assess um, the impact of IPCs in this group of patients. The systematic review included 13 patients and 13 studies and 325 patients. Two studies gave the indication that there may be a reduction in hospitalizations, and this is not surprising because IPCs are inserted as outpatient procedures, and there is also a suspicion of reduced hospital admission because these patients may need less subsequent pleural procedures compared to therapeutic thoracentesis. The systematic review could not estimate the duration of IPC because this was not included in many of the studies that were described. And if you look at the forest plot, the estimated average rate of spontaneous pleurodesis in this group of patients was in the range of about 50%. There has been a more recent multi-center randomized controlled trial comparing IPCs and therapeutic thoracentesis in this group of patients. There were 33 patients randomized to IPC and 35 to therapeutic thoracentesis. And you can see that at 7 and 28 days, there was no significant difference in dyspnea between the two groups as measured on a visual analog scale. The pleurodesis success within 12 weeks also showed no difference. There was, however, a big difference in the amount of fluid drained. As you can see, over 7 liters in the IPC group versus just under 3 liters in the therapeutic thoracentesis group, and which goes on to show that in this group of patients, the effusion will continue to recur if you do not treat the underlying disease. So this is related to underlying disease control. The other interesting findings in this paper was that the IPC group had a higher rate of adverse events at 12 weeks, as well as a lower serum albumin level at 4, 8, and 12 weeks, which leads to the suspicion that if you continue to drain these effusions, you're going to lose albumin. And in this group, in this study, these patients were drained up to 3 times a week. We go back to the systematic review on IPC complications in benign diseases. The top complications remain infections, right? And I want to say that in this systematic review, major complications were defined as those that required either premature removal or replacement of the IPC, produce serious infections such as empyema or sepsis, produce pneumothorax, or required additional invasive pleural procedures. So some complications such as the use of thrombolytic therapy to treat IPC blockage was actually considered a minor complication, which some of us may not consider. If you look at the data from malignant pleural effusions and the use of IPCs, where there is a lot more experience, you will see that infections, especially pleural infections, is a real problem. They typically occur 6 to 8 weeks, and I've listed the commonest organisms. And we don't have to actually remove the indwelling pleural catheter. Some people believe the pleural catheter may be colonized the same way urinary catheters are colonized. There is some data to suggest that patients who do get these pleural infections have a higher rate of pleurodesis. If you look at the underlying causes of IPC-related pleural infections, you can list the patient-related factors and the clinician-related factors. And in the patient-related factors, it is the inability to adhere to aseptic technique, which we must target aggressively. In the clinician-related factors, it is the insertion procedure that needs to have rigorous adherence to aseptic technique. Other complications include symptomatic loculations, which typically we will leave alone if the patient is not too symptomatic. But if the patient is really symptomatic, these patients may need fibrinolytic therapy instilled via the IPC. and sometimes you can get catheter blockage, and we have a protocol on how to use either flushing with normal saline, and if that doesn't work, a small dose of tissue plasminogen activator to unblock these catheters. I'm going to end with the prognosis of refractory non-malignant pleural effusions, because that is what marks this out as a special category of patients. Pleural effusions in heart failure may not be a poor prognostic marker, but if it is refractory, then it does become a poor prognostic marker. You must understand that these patients typically have other things that are going on, including hypotension from cardiac failure. They may have concomitant renal failure from a cardiorenal syndrome. They have electrolyte imbalances, and they're already being treated on a whole range of medication. We have seen that from systematic reviews, the estimated one-year mortality for refractory effusions and cardiac failure is up to 50%, renal failure 46%, and liver failure up to 26%. And you can see that this is potentially worse than patients who have malignant pleural effusions. In fact, patients who have bilateral pleural effusions have a worse survival than patients who have a unilateral effusions, and patients who have a transudate have a worse prognosis than those who have an exudate. This is in the context of non-malignant pleural effusions. So you shouldn't forget palliative care and opiate therapy in patients who require it. So if you think about what we should do, it will depend. It will depend on, one, how fast the pleural effusion recurs after drainage. Two, what is the likelihood of controlling underlying disease and how much control has already been done prior to pleural drainage. And three, the prognosis and functional status of the patient. So my take-home messages to all of you is that refractory non-malignant pleural effusions carry a grave prognosis. As I said, it may be worse than malignant pleural effusions. Leitz criteria may not be helpful, and we need to find new biomarkers because you need to identify the underlying cause and treat it. Dual pathology may exist, and you need to treat that too. Always treat the underlying organ failure. When that doesn't succeed, and if the patient is dyspneic, you can consider therapeutic thoracentesis, pleurodesis, or indwelling pleural catheters. And I've outlined when you will need to use which of these interventions. Thank you very much, and I wish you all a wonderful Congress. Thank you for the invitation.
Thank you, Anand, for that comprehensive talk. So we'll move to the next lecture. Professor Najib M. Rahman from UK. He's a professor of respiratory medicine, director, Oxford Trials Unit, lead Oxford Pleural Translational Laboratory UK. He's a dear friend of our college. So over to you, Najib, on value of ultrasound in pleural disease.
Good morning, ladies and gentlemen. My name is Najib Rahman. I am Professor of Respiratory Medicine at the Oxford Centre for Respiratory Medicine, and I also lead the Oxford Pleural Unit. It's my absolute pleasure to present to you today at RESPIRE 13, and it's my honour to have been invited by the Sri Lankan College of Pulmonologists. What I will cover in my lecture over the next 20 minutes or so is the use of ultrasound in pleural disease. So we will look at the evidence for the use of thoracic ultrasound. I will cover some basic appearances. We will then look at pathology, and then finally talk about the advanced use of ultrasound by pulmonologists. This includes pneumothorax assessment, pre-thoracoscopy conditions, real-time techniques and biopsies, and intercostal artery identification. And throughout, I will try and take an evidence-based approach. So the first question is, should we as physicians be using ultrasound? Surely with an X-ray, maybe with a CT, and maybe with clinical examination, we do not need to use ultrasound. Well, in fact, the evidence is very much against this statement, and let me just go through some of these bits of evidence. So we have known, if you look at my slide down at the bottom right here, for over 30 years that ultrasound is more sensitive than chest radiography in the detection of pleural fluid. You will all know that chest radiographs can detect up to 200 mils of fluid, thoracic ultrasound is able to detect at least 5 or 10 mils of fluid. It increases procedure accuracy as written here, and it's associated with a low complication rate when used for interventions. Not only that, but I'll come on to this, by using thoracic ultrasound at the bedside, we gain additional diagnostic information that is useful for us planning patient care, but also for our patients. And I would just highlight these two bits of data, which I think are the two killer bits of data that really tell us that thoracic ultrasound not only should be used, but should always be used. And in my view, it is now mandatory, if you can, to use ultrasound when diagnosing patients with pleural fluid related conditions. So this was by Andreas Diakon, who is a pulmonary physician in South Africa. He did a very simple study. He took 50 patients who came into the A&E department with an X-ray that looked like pleural fluid, and he then asked clinicians, including very senior clinicians, to percuss the chest and tell him where they would put a needle and if they would put a needle in. He then immediately conducted an ultrasound. And what he demonstrated was that even a very experienced physicians, 15% of their clinically specified puncture sites were inaccurate, and of those 15%, 80% were aspirated under ultrasound. In all, ultrasound avoided organ puncture in 10% of cases, and the very interesting thing about this paper is that it did not matter what the seniority of the physician was. So even an early trainee or a very experienced pulmonologist, the ultrasound avoiding organ puncture was always around 10%. So this is a small direct comparative study showing that in the real world ultrasound saves problems and saves inaccuracy. Now this study here, the Macaldi study, this is an enormous retrospective multivariate modelling study, that's MV modelling, of over 60,000 thoracentesis, and by chance around half, 47%, were without ultrasound. Looking at the predictors of complications, ultrasound came out as a predictor of not getting a complication, reducing your pneumothorax rate by nearly 20%. So we have small scale and large scale data that ultrasound should be used for pleural fluid conditions, and really I think the argument has now been made. Now I'm just going to spend a couple of minutes showing you the image orientation for all of the videos that I will show you in the next few minutes. So here is our patient on their side. Here is the diaphragm in red, and then the pleural effusion in blue. And this is exactly the radiological convention, that the left side of the picture is the head side and the right sided picture is the leg side. If you set up this way, it means you are always expecting abdominal contents to be on the right and head contents and lung and pleural fluid, as you see here, to be on the left hand side. So what would we expect to see in this case? So this is obviously a large pleural effusion with a meniscus, a diffuse opacity in the right lower zone. What would we expect to see on ultrasound? Well, this is what it looks like on the video. So in black is the fluid. Ultrasound penetrates through fluid, and therefore you can see distant structures, and that's very critical, that you can see through it, not just black, but you can see through down below. And here we have the atelectatic lower lobe. So this is the lower lobe that has been compressed passively by fluid surrounding it. You can then see the mediastinal structures and the corner of the left ventricle, and indeed this black structure here is probably the pulmonary artery. So that's what we normally look like, and this would be regarded as a simple free-flowing effusion causing passive atelectasis. But ultrasound can tell you much more than this, so it can give you some very specific features of the effusion and indeed of the lung underlying it if an effusion is present. So here is an example of a patient presenting with a fever and a basal opacity on the chest x-ray, and what we see here is a significant effusion associated with these internal fibrinous septations. So this is a complex septated effusion. Not only that, but the lung here, this grey structure, which as you can see is very bright in places, brighter than the associated abdominal organ. This is heavy lung consolidation with some obstructive pneumonitis and a septated pleural infection. This is a condition which you see much more of than I do. This is TB pleuritis, so there is a low echogenicity effusion in the middle here. The diaphragm is over here, and you can see pleural thickening all the way around the outside. So this is parietal pleural thickening, diaphragm pleural thickening, and visceral pleural thickening, and this in fact was a pseudochylothorax after poorly treated TB. So we have established that ultrasound is very reliable at identifying fluid, but as a proceduralist it identifies much more than just fluid. So here's an example of a patient with a very large effusion on chest x-ray, which we were about to conduct a thoracoscopy on. We did a thoracic ultrasound in the mid-thoracic area, fourth intercostal space, in order to try to enter our trocars, and you can see here that there is something in the middle of the pleural effusion. Here is the lung here is the lung here, and something is climbing up and seems to be stuck to the parietal pleura, and this in fact was a piece of tethered lung because of a previous pleural procedure that had created this area just here. So we of course went a couple of rib spaces lower and then entered our trocars below, and when we looked back up at thoracoscopy, this is what we saw. So here is the lung, here is the chest wall, here is the pleural space. If we had put our trocars into here, then we may well have caused significant lung damage, so it's an extremely useful technique. Here is a case that was referred to us, a young man with fevers, very high CRP, lots of chest pain, and this was thought to represent a right basal pleural infection. The referring general physicians had put in a needle blind, had not obtained any fluid, and therefore sent him to us. Now, I think we as pulmonologists would regard this shape as probably not most in keeping with a pleural effusion. Nonetheless, it's very difficult to know what's happening down here. So we turn to our ultrasound probe, and this is what we see on the ultrasound. So here is the liver in the darker grey. There is an effusion, but it is tiny, about 0.4, 0.5 centimeters just up here. And this large structure here is the entire lower lobe, which has completely consolidated. And in fact, the black areas here, you can see micro abscesses and indeed the pulmonary artery within. So it gets you out of trouble, not just when you should do a pleural procedure, but when you shouldn't do it as well. And it is extremely good at diagnosing consolidation, as long as the consolidation has reached the visceral pleura. Now, it has value above and beyond this even, so as a diagnostic tool, and I mean three separate things here, which I'm just going to discuss the evidence for. The first is echogenic swirling, the second is an inverted hemidiaphragm and what that might mean, and finally diagnostics of malignant effusion, pleural thickening and nodularity. So this is a case of a very large effusion. As you can see, here is the diaphragm, here is the visceral pleura, and here is a very large effusion, but within you can see these little dots moving around like a snowstorm, and this has been described in the literature as echogenic swirling. So the question is, what does it mean? We were taught when we trained in ultrasound 20 years ago that this meant that this was an empyema or blood, or at least definitely an exudate. We have prospectively assessed this now in two different studies. The first was by Rochelle Ashiak, who was my fellow up till a few years ago. She looked at this in 140 patients and looked at the diagnostics of these using echogenic swirling. So how good is echogenic swirling at separating exudate and transudate? Well, it's got a very high positive predictive value, but not 100%. So it is 90% predictive of exudate, meaning you will miss 10% of exudates, but it's very poorly sensitive and it has a very poor negative predictive value. So if you see this appearance, then it is likely to be an exudate, but not necessarily an exudate. And perhaps more interestingly, my other fellow at the time, Majid Hassan, he did this great study in a very small number of patients, looking at whether echogenic swirling had a relationship to pleurodesis outcome, i.e. Was the pleurodesis successful in a small number of patients with malignant pleural effusion. And he demonstrated that if there was echogenic swirling, then you often had pleurodesis failure, whereas if there was an absence of echogenic swirling, then there was often successful pleurodesis with a very strong p-value. Now, we don't know why this should be, and we don't know what it means, but further work is required. Now let's ask about symptoms. So how do you know that the patient that you see with a large effusion will benefit from your therapeutic thoracentesis? Well, we have recognized for many years that the ultrasound does guide you to some extent in this area. Apologies. This is what then happens. So there is still a significant effusion, there is still large atelectasis of the lower lobe, but the diaphragm is of normal shape and normal movement, and we many years ago recognized that this was associated with a very significant improvement in their breathlessness. Now, my colleague Gary Lee in Perth has done this wonderful study which has essentially proven this, called the PLEASE study. So what they did was they took 145 patients who were symptomatic, who needed to undergo pleural aspiration, and they assessed their breathlessness pre and post drainage, and also quality of life measures along with ultrasound findings. Interestingly, if we look at the association of spirometry, there's a very small change in spirometry, only about 100 or 200 mils, although it was statistically significant, clinically not that significant, whereas their respiratory rate didn't particularly change and their oxygen saturations did not change at all. And this is important. You will very rarely improve oxygenation by draining effusion, but you will improve breathlessness. Now, when they looked in multivariate modelling at the predictors of breathlessness relief, there were a few, but one of the most important was an abnormal diaphragm movement before. So they have proven what we have suspected for some time. If you see that flattened diaphragm and the poor movement, the patient is likely to improve after your thoracentesis, which is important in terms of practice. Now, how about diagnostics? So here are two still images. Here is the diaphragm with a large nodule and a smaller nodule. Here, many abnormalities here. There is visceral, craggy nodularity, a discrete pleural nodule here, and more pleural nodularity over here. So myself and Nagmi Qureshi, some years ago in Oxford, we asked the question, can we use thoracic ultrasound in the diagnosis of malignant pleural disease? And we did a prospective study of 52 patients. And this is what we found. We compared it to the historical standard of CT diagnosis of malignant pleural effusion, the Leung study you will all be very aware of. And I'll just point out a few things. Firstly, there are parameters that ultrasound detects that CT cannot detect. So CT does not look at the visceral pleura, it doesn't look at the diaphragm, it doesn't look at the diaphragm layers, and it can't see diaphragm nodules because the diaphragm is moving during the CT scan. And you can see that overall ultrasound had an extremely high specificity, 100%, and a sensitivity of 79% for the diagnosis of malignant pleural disease, which was better than CT. Now, since we did this study, this has been replicated by colleagues in Germany and elsewhere. This publication is from 2014 from both Italy and Germany, and they essentially found exactly the same thing. So the overall sensitivity of ultrasound was up at 80% with a specificity of 84%. So this is a very good technique to triage your patients into likely malignant effusion or not. It should be stated that these studies were done in areas of low prevalence of TB, and there hasn't yet been a study comparing diagnostics for malignancy, TB and other, and maybe that study needs doing. So this is an example of how well it works. This was a patient pre-thoracoscopy. You can see that they have craggy pleural thickening here. There is a big nodule on the diaphragm here, and there is a mass pistoning in and out of the costophrenic recess just here. Echogenic swelling. This is highly likely to be malignant. Just remember the ultrasound picture. This is what it looks like at thoracoscopy. So here is the craggy pleural thickening, here is the diaphragmatic nodule, here is the thing in the costophrenic recess, and this was a case of advanced lung adenocarcinoma. Okay, let's move forward then for ultrasound 4 procedures. Of course, it's possible simply to scan the chest, decide where the fluid is, put the ultrasound down, and then insert your chest tube. However, in Oxford, we encourage people to do things real time, and I'll just show you why. So here is a case, as you can see, of a septated pleural effusion. There is consolidated lung to the left of the picture, and there are multiple septations. We really want to get to the largest septation to have the best drainage effect. So using a real-time technique, and this was our finder needle, we were able to anesthetize the pleura, and then you can see here we pushing in a bit of local anesthetic, showing that the tip of the needle is just here. We then use our finder needle to penetrate first one and then a second septation to end up in the largest locule, and then in the largest locule we then feed in our guide wire. So this is the guide wire, as you can see just here. We then dilate and and make sure that our tube ends up in the largest locule. Once it's in the locule, we can use agitated saline to demonstrate its position, which is shown here. So these little dots are bubbles of air, and we have confirmed that our chest tube's tip is somewhere down here. So it's a really very useful technique. Now, if you're able to do real-time skills, and I'm aware of people like Nandika who are with you, who trained in Oxford, who are able to do these techniques, if you're able to do real-time techniques, then you may well then be able to go on and do image-guided pleural biopsy. So the rule in ultrasound is if you can see it, then you can biopsy it. Should we as pulmonary physicians be doing ultrasound-guided biopsy? Well, there is good data to support its use. So Rob Halifax, my fellow nearly 10 years ago now, did this prospective study of 50 patients, demonstrated sufficient material of image-guided biopsy by physicians in 94%, and interestingly we could do it in those who had failed thoracoscopy with an overall sensitivity of 92%. And then colleagues in South Africa, Kearney Kergelenenberg, he has done this really interesting study, prospective 100 patient, where they use ultrasound to triage the subsequent biopsy technique. And this is what they did. So they do ultrasound at the beginning of the pathway, and then they divide them according to the ultrasound findings into pleural base mass lesion, pleural thickening or no pleural thickening, and then depending on what they find, they either do a thoracoscopy or an image-guided Abrams or cutting needle biopsy. And what they came up with then is a very high overall diagnostic yield in the region of 90%. So this is probably a sensible way to use ultrasound, not just to do the biopsy, but also to triage the biopsy technique. This is the cutting needle that we use. So we use a needle that extends into the lesion, has a little core, and then a spring-loaded core that biopsies the lesion of interest. And this is an example. So you can see the tip of the needle here. It's crossing the thickened pleura just there, and then you will see that the operator presses the button and takes a biopsy just there. Here's another example. So you can see the needle going in under real time, and then there's a little the end is being fed out here, pulled back, and then there's a click just there which takes a lovely tangential biopsy of the pleura. The other area that we use ultrasound a lot for is in pneumothorax induction for thoracoscopy, that is thoracoscopy in patients who do not have any pleural fluid. It's useful in two areas. Firstly, it can predict who it's going to be possible to induce a pneumothorax, and secondly, it can help you safely in inducing pneumothorax using real-time ultrasound. So this is a piece of work from John Corcoran, who was my previous fellow. He looked at 207 thoracoscopies, 37% required pneumothorax induction, and of those 13% could not be induced, and we looked at the factors that predicted if they could not be induced, and in fact lung sliding was extremely associated with a successful pneumothorax induction. So this patient, if they needed a thoracoscopy, we would predict, because there's this beautiful lung sliding, that the visceral pleura is not adhered to the parietal pleura, and therefore pneumothorax induction will be successful. Whereas this patient, who also needs a thoracoscopy, you can see that there's no lung sliding, and therefore it's likely there's adherent lung, and maybe we need a surgical biopsy. This is what pneumothorax induction looks like under real time. So here is the lung, and there's the air coming in and replacing the lung, telling you that it's going to be safe to induce a pneumothorax. Just show that again. Here's a bit of fluid, and then just there is the air coming in and replacing. Now we've tried to extend this a little to increase the safety. So obviously pleural procedures are potentially dangerous. We did this work some years ago demonstrating that the intercostal artery, especially posteriorly, has a very variable course before it hides under the rib above. And we actually measured this quantitatively, showing, so down here is the distance from the spine. So here is at the spine, and here is the lateral distance from the spine up to 70 millimeters, whereas up here, here is the rib below, here is the rib above, and you can see that the intercostal arteries are very variable until you get to about 6 centimeters away from the spine. So this is why we avoid the posterior part of the pleural space, but it is variable. Now, Matt Salamonson, who's a physician in Australia, he did this great study trying to see if pulmonologists using ultrasound could detect the intercostal artery using Doppler. So he took 50 patients who were undergoing CT scan with contrast, used an expensive and a cheaper ultrasound machine, and then they labelled the intercostal artery with a fiducial marker using CT as the gold standard. So this was them detecting the intercostal artery, demonstrating that it had the right waveform, and then this is them marking it with a fiducial marker just here. What they demonstrated was that the ultrasound had good sensitivity, whether it was low end or high end. It just took a little longer with a portable ultrasound machine. So it's clearly possible to identify the intercostal artery. The problem is this was not in patients with pleural fluid, and they weren't undergoing procedures, and often the CT and the ultrasound identified different parts of the intercostal artery. So we therefore needed real life validation, and my colleague Ihab Badawi has now done this. So this was a screening study that we did here in Oxford. What we do in Oxford is we find the place that we want to do the intervention, and then we fan the ultrasound probe through the same intercostal space with the Doppler on, looking for the intercostal artery. In this study we had nearly 600 procedures. We screened in 563 looking for the intercostal artery, as you can see just here, and in summary we very often identified the intercostal artery at the point of intervention. So for thoracoscopy in 41%, for image guided biopsy in 73%, whereas for drain insertion and IPC more like 50%. So as your skills increase, I would encourage you to do this. This is what it looks like on Doppler. So here's a bit of fluid colour sign, which is just the pleural fluid moving, but this is the intercostal artery laterally and more posteriorly. Here is a pleural mass lesion, which we're going to biopsy here, and we've identified the intercostal artery over here. And finally, after biopsying, if you're worried, you can identify bleeding, as you can see just here. So there's echogenic material collecting in the fluid, and when we put the Doppler on, we can see that we have perforated intercostal artery, meaning we can put in interventions straight away. Now for my last 2 minutes, I'll talk about ultrasound as a predictor, so its final use. We conducted this study, which is called the SIMPLE study, essentially asking the question, can we use malignant pleural effusion talc pleurodesis and use ultrasound to predict which patients are having a successful pleurodesis? So simply put, we took patients who were undergoing either thoracoscopic poudrage or talc slurry pleurodesis. You will know that the BTS guidelines cover
Recording is over.
determined whether they had a shorter hospital stay and a successful pleurodesis. Now, thoracic ultrasound guided management involved scanning the patient in 9 thoracic positions, so 3 posterior, 3 lateral and 3 anterior, and in each space deciding if they had present, questionable or absent lung sliding, meaning the lowest score was 9 and the highest pleurodesis score was 27. And this is what it looks like on B mode and M mode. So this was just before pleurodesis, normal lung sliding and the typical seashore sign. So this patient would score at this point a 1 because they have full lung sliding, whereas the day after pleurodesis, you can see here there is absolutely no movement, the barcode sign, and this would have scored a 3. So by scoring more than 20, we could withdraw the chest tube and send the patient home. What did we find? Well, we found that there was a significant reduction in the time in hospital, which was excellent, and the average length of stay was reduced by about 1.5 days. So this clearly worked. The issue is, does it occur with any disadvantage, i.e., was the pleurodesis failure rate higher? In fact, when a non-inferiority comparison, the pleurodesis failure rate was no different. And indeed, when we looked at the health economic analysis, using ultrasound saved us in the region of £500 to £1,000 per patient, and therefore this was highly cost effective. So our conclusions from the SIMPLE randomized trial are that ultrasound reduces hospital stay in malignant effusion pleurodesis, it reduces the time that the tube is in the chest, and it does not impair pleurodesis, so we think this should now be standard of care for all pleurodesis. Okay, that's the end of my talk. Let me just summarize your ultrasound in practice, it definitely increases safety, and I think it should be mandatory for all pleural procedures, even very obvious ones, because you sometimes find the left ventricle or some tethered lung. You can work towards advanced ultrasound, including pneumothorax induction and high-yield pleural biopsy, and in the future we may be using it for screening intercostal arteries, pleurodesis assessment early in treatment, and maybe even advanced diagnostics. And with that, I thank you for your time, and I hope to join you for questions. Thank you very much indeed.
Thank you very much, Professor Rahman, actually giving the wonderful presentation. I think with evidence-based management of the use of ultrasound and the different aspects of pleural disease management. Now we will go into the next presentation. It's a medical management of empyema in the era of VATS by Dr. Rakesh Panchal. He's a consultant respiratory physician, the lead physician for pleural diseases and the intestinal pulmonology and the interventional pulmonology at the University Hospital Leicester, NH Trust, and the Institute of Lung Health. It's Dr. Panchal.
Hello, good morning from England. My name's Rakesh Panchal. I'm one of the chest physicians in Leicester, and I've met a lot of you when I was there for the RESPIRE 11 meeting in 2019. I'm sorry I can't be there with you today, but I'd like to thank the Sri Lanka College of Pulmonologists and the organising committee for inviting me to present at your conference. So in the next 20 minutes, I'm going to talk about the medical management of empyema in the era of VATS. So I work in Leicester, which is in the East Midlands. We're one of the largest hospital trusts, and we have 3 hospitals in our trust. That's Glenfield at the bottom right, and we're affiliated with the University of Leicester. So I have no conflicts of interest to declare for this talk. And in the next 20-25 minutes, I'm going to talk to you a little bit about the history of pleural infection, predictors of outcome, and the evidence base for intrapleural fibrinolytic surgery. And there's the new BTS guidelines on pleural disease, which should be published later this year, and a little bit about ongoing research in the field. So you'll all be familiar with Sir William Osler's quote that empyema needs a surgeon and 3 inches of cold steel instead of a fool of a physician, and the late Richard Light's famous quote that the sun should never set on a paraneumonic effusion, and we probably all quote this to a lot of our colleagues when seeing patients. So in terms of the history of pleural infection, it's been around since Egyptian times. Imhotep was an advisor to the pharaohs, but Hippocrates is sort of the father of pleural infection. Hence the first one is stated that empyema, if an empyema doesn't rupture, death will occur, so that it needs to be drained. But at that time, drainage techniques were open, quite barbaric, and with a high mortality. Both Dupuytren and William Osler had an empyema. William Osler actually ironically died of a post-operative surgical complication, whereas Dupuytren declined surgery. But it was after the World War when the Empyema Commission suggested that closed tube drainage might be better, and this reduced mortality, and Streptococcus species predominated. And obviously since then we've had the advent of antibiotics. In the 80s, the late Richard Light suggested that we should put chest tubes in pleural infection when the pH is less than 7.2, and that still dictates a lot of our management. We've had a number of studies since then, which I'll talk about shortly. So pleural infection, we know about 20% of patients with pneumonia will get a paraneumonic effusion, about 5 to 10% will get an empyema, and these patients have long protracted hospital stays. And about 15% will need surgery, and about 20% will die with an empyema. Management still consists of broad-spectrum antibiotics and a chest tube, and then we wait for medical treatment to fail before we consider further treatment. And we know that time to intervention is key in reducing adverse outcomes. But the question is, what intervention? Does a chest drain antibiotics alone suffice? Should we consider early intrapleural fibrinolytics? What's the role of early medical thoracoscopy, or possibly early thoracic surgery in the era of VATS? So you'll all be aware of this diagram, that pleural infection sort of progresses from a non-complicated paraneumonic effusion in the early exudative phase to a complex paraneumonic effusion in the fibrinopurulent phase, and obviously an empyema with organized loculated phase at a later stage. And patients can present to us at any of these points. When we see this sort of classic X-ray of a lenticular effusion, we know that we're probably likely to be dealing with an empyema with pus. Thoracic ultrasound is absolutely invaluable in pleural infection. So you may see this sort of image where there's an echogenic unilocular effusion, which will hopefully respond to drainage. But you may see septations developing. It might become more organized. And then this sort of heavily loculated collection where you think a drainage alone may not help, and that might you need to consider alternatives just as fibrinolytics or even surgery. This is an ultrasound image showing septated collections. The one on the left may respond to drainage with the fibrin strands breaking down, but perhaps the one on the right might not. CT is key. The split pleural sign you'll all be familiar with, where the visceral and parietal pleura peel away because of pleural enhancement and extrapleural flat enhancement, and it can be helpful in differentiating peripheral pulmonary abscesses from pleural infection. So in this image at the top, you can quite nicely see the parietal and visceral pleura splitting away with the collection in the middle. You may see gas-forming organisms, again indicating an empyema. But sometimes if you see surrounding lung tissue, you might think, is this a pulmonary abscess rather than a pleural collection? It can be difficult to differentiate, but this could lead to bronchopleural fistulae if you insert a chest drain inadvertently. So what are the outcomes of predictors of outcomes? So the BTS guidelines say that microbiology doesn't really affect your mortality, length of stay, or surgery. Septations and complex septations do, and certain clinical parameters, such as the RAPID score, may determine mortality and length of stay. So the RAPID score is an outcome prediction score using previous interpleural studies, the MIST-1 and MIST-2 cohorts, to stratify mortality at 30 days and length of stay. And according to renal function, age, presence of purulent fluid, whether the infection is community-acquired or hospital-acquired, and based on the patient's nutritional status using their albumin, they categorize patients at a low, medium, and high risk. And obviously, the overall mortality in the pilot study was that about 10% at 30 days and 20% at 1 year. And that as your RAPID score increased, your 30-day mortality increased as well. Again, going back to ultrasound here, in the two images at the bottom, image 3 and image 4, in this heavily septated collection, you'll probably still insert a chest tube, but the chances of success are probably slim, and you may want to think about intrapleural fibrinolytics. So the MIST studies are the key studies that have been published so far. MIST-1 in New England showed that streptokinase twice a day for 3 days versus placebo made no difference. But actually one of the key studies, and this regime is still widely practiced, is that of TPA and DNase. In this study, there was 4 arms, and in the TPA and DNase arm together, there was a 30% reduction in effusions radiologically, and 3/4 of patients had fewer thoracic surgical referrals. And it's important that TPA and DNase are given together because they work synergistically. However, worldwide TPA and DNase practice varies. In this study by Gary Lee's group in Australia, they did a survey of around 49 pleural physicians or physicians who are doing pleural research, and they found out that doses varied, number of doses given varied, and the dosing frequency varied, possibly due to cost, availability, and problems with administration. This led to 2 studies by Gary Lee's group, the ADAPT-1 and ADAPT-2. In the ADAPT-1, they halved the dose of TPA because of perceived concerns about bleeding risk and cost. And they found that half dose TPA, so remember in the MIST-2 trial, they used 10 milligrams of TPA and 5 milligrams of DNase. And if you halved it, they found out that it was still safe and effective. And to try and establish the lowest effective dosing regime, they actually halved it even further in ADAPT-2, which was published last year, and used 2.5 milligrams of TPA, and found that potentially it may still be effective. This is an excellent paper which I'd encourage you to read by Udit Chadha and Abhinav Agrawal in the United States, published in The Lancet, which gives a consensus statement on using intrapleural fibrinolytics, and I'll quickly take you through this. They suggest that monotherapy, so TPA and DNase alone, should not be used because it's not effective, that you can administer them concurrently, and that the dose of 5 milligrams of DNase and 10 milligrams of TPA still remains the dose of choice because that's what's been studied. That you should clamp the drain for at least an hour when you give these 2 fibrinolytic agents, and that you don't have to give 2 doses. So you don't have to give it twice a day for 3 days. The number of doses should be individualized to the patient, depending on their CRP, perhaps depending on the septations, depending on the radiology, and the clinical picture of the patient. If they're improving, maybe 1 or 2 doses might suffice. If the patient are taking anticoagulants, antiplatelet agents, it's important that they are held before you administer it. And in terms of whether you want to give fibrinolytics first or surgery, they were saying that fibrinolytics perhaps should be the initial or subsequent to the treatment, and that if you've got a stage 2 early fibrinolytic stage, you probably want to use fibrinolytics first. But if the collection's very heavily organized, then perhaps surgical or VATS approach first, and if that fails, fibrinolytics afterwards might benefit. Obviously, there are patients in whom fibrinolytics may be contraindicated, and there you could use pleural irrigation therapy, so surgery or fibrinolytic, fibrinolytics are contraindicated. You'd use saline pleural irrigation. I'll talk a little bit about that shortly. There's always been risk about bleeding with fibrinolytics, and last year there was a study published in Chest, which looked at just under 2,000 patients across the USA and UK who had one dose of intrapleural fibrinolytics, and they found out the overall bleeding risk with 10 milligrams of TPA was only 4.1%, and that if you used a half a dose, because of the perceived risk of bleeding, there was no difference in bleeding. So if you use half dose TPA at 5 milligrams or full dose 10 milligrams, there's no difference in bleeding risk. If you give fibrinolytics with anticoagulation, there's obviously a bleeding risk around 10%, which is reduced if you hold the anticoagulation. Similarly, bleeding risk increased with a higher rapid score, higher urea level, and low platelets, as one would expect. So the pleural irrigation trial, in this trial in 2015 by Nick Maskell's group in Bristol in the UK, they used 250 mils of normal saline given 3 times a day via the chest drain over gravity. So they gave it 3 times a day over 1 hour, and they looked at the pleural volume change on their CT and the referral to surgery and the length of stay. And they found out that there was a 32 versus 15% reduction in the pleural volume on a CT if you used saline irrigation, and the odds ratio of referring to surgery was reduced 7-fold if you used pleural irrigation. So perhaps pleural irrigation is an option in patients who have a contraindication to fibrinolytics and surgery. How about medical thoracoscopy? Medical thoracoscopy allows you to drain the collection. You can break down fibrin strands. You can position a chest drain and even take a pleural biopsy, not just for histology, but for culture. But it's not in the international guidelines, and it's not in the new British Society guidelines either. But it could potentially be first-line technique in patients who are unsuitable for surgery. So there's been a number of studies. One is a systematic review by an Italian group published a couple of years ago. There is a randomized controlled trial of fibrinolytic versus thoracoscopy, and also a cohort study published by Poletti's group only this year. In the UK, there was a feasibility study called the RESPIRE study for medical thoracoscopy early in pleural infection, but it demonstrated failure. That's because UK thoracoscopy services aren't really set up. Most centers do thoracoscopy once a week, and obviously if you have a pleural infection that pitches up and you want to do a thoracoscopy early, you may have to wait many days. So the UK is certainly not set up for providing thoracoscopy services early for pleural infection and empyema. So in the systematic review, they found that the pooled success rate after failed chest tube was when thoracoscopy used first line was 95%, complication rate was low, and that fibrinolytics were only required in about 9% of cases. And that if the pleural fluid culture was negative, the success was higher. Adnan Majid in the US did this randomized controlled trial, and they included patients with a septated complicated effusion or an empyema which failed to drain within 48 hours, and they randomized these to medical thoracoscopy, so rigid or semi-rigid, versus intrapleural fibrinolytics, and their primary outcome, surprisingly, was length of stay. One of the limitations in this study was that there was no information on radiological resolution or referral to surgery. And obviously, patients initially had a small 14 French drain, or there was less than 14 French drain, followed by a large drain at thoracoscopy. And there was no data on whether semi-rigid or rigid thoracoscopy outcomes were better. However, in their data, when they showed therapeutic failure, they found out that there were similar rates of failure in both the fibrinolytic and medical thoracoscopy group. So is there clinical equipoise, and really is medical thoracoscopy better than intrapleural fibrinolytics? A more recent study, which is only just come out, and there's no full journal access to it in respiration, is again by the Italian group. And this was a retrospective cohort study where they looked at about 131 patients according to ultrasound categories. So they said whether the effusion was free-flowing, viscous, or organized. And they found out that medical thoracoscopy was successful without interpleural fibrinolytics in about 3/4 of cases, and that it was much more effective if there was a free-flowing viscous stage rather than at a later organized stage where it wasn't as effective, and perhaps VATS might be better. So how about thoracic surgery? Well, the principles of thoracic surgery are drainage, deloculation to debride the area, and entrapped lung with pleural infection, where the visceral pleura is thickened like orange peel, they will remove that. The American Association for Thoracic Surgery produced a consensus statement on management of empyema in 2017, and as one would expect, they suggested the primary treatment strategy for empyema should be thoracic surgery first line. This was followed by a Cochrane review, which showed that there was no statistically significant difference in mortality between surgery and non-surgical treatments, and they suggested there was insufficient evidence to assess the impact of fibrinolytic therapy. However, things have moved on. Last year in the Annals of American Thoracic Surgery, there was a retrospective study looking at fibrinolytics versus surgery. So this is in the US over 3 years, and they looked at just over 500 patients who'd had any dose of intrapleural fibrinolytics, but had at least 5 or 6 doses. And in about half of them, they looked at patients who went for surgery first, and just under half had fibrinolytics first. In those who had surgery first, only 10% required further treatment, versus those who had fibrinolytics first, about 40% required further treatment. In the surgery arm, 6% subsequently required fibrinolytics, and in those who had fibrinolytics, about 20% needed surgery afterwards. So they suggested that perhaps surgery should be considered early in pleural infection. However, the limitations of this are obviously it was a retrospective review, it wasn't randomized, and actually when you drill down to the group of patients who received 10 milligrams of TPA and 5 milligrams of DNase as per the MIS2 protocol, none of them needed surgery. Another bias in this was obviously about 80% of the patients in the study were admitted under the surgeons first, and that's probably unlikely in a lot of our setups. A lot of these patients would present to medicine first. Surprisingly enough, only 13% of those admitted under a physician ended up having surgery, or were referred to surgery. And I suppose overall, a lot of our healthcare systems are not really set up for patients going straight to early surgery. Most of these patients will have chest drain antibiotics, and we will wait for that to see if there's any treatment failure before referring to surgery. So I don't think worldwide healthcare systems are set up for patients to have thoracic surgery so early in the course of their illness. So in the UK, there's been a feasibility study of MIS3, and we participated this in Leicester, looking at early surgery versus early fibrinolytics. So in this study, there were patients who were randomized to standard care. So they had standard care for 24 hours, antibiotics and a chest tube to see if there's any improvement. And if there wasn't, they were randomized to either carrying on with standard care, so regular chest drain flushes, antibiotics, or fibrinolytic treatment as per the MIS2 protocol, or early VATS. And in the standard care arm, about just under 50% of patients were fine with standard care, 30% needed fibrinolytics, and about 20% needed surgery. In the fibrinolytic arm, about just under 80% were fine with just fibrinolytics, and about 10% required nothing, no treatment, and some 10% required VATS. So the early signals for this are that early intervention with something other than just a chest drain and antibiotics might shorten length of stay, and that fibrinolytics would shorten recovery and early resolution of pain. And this will hopefully lead to a further larger randomized controlled trial. This was presented at the Winter BTS by Ihab Badawi, who was the first author on this, and it's to be published later this year. Interesting, there's more interest in early fibrinolytics versus early surgery, and the Danish group have published this protocol for the 5-VAT study, which will be hopefully ongoing this year. So there's more interest in early surgery versus early fibrinolytic trials, so watch this space. How about other important studies in pleural infection? Well, in children, there's some evidence for giving for steroids, as well as antibiotics and drainage in infection. The STOP trial published in the Blue Journal showed that intravenous dexamethasone had no benefit in adults with parapneumonic effusion. The audio study looked at ultrasound-guided pleural biopsies in pleural infection. So you will all be familiar that pleural fluid and blood cultures often do not reliably identify the pathogens or the bacteria in a parapneumonic effusion, so we give broad spectrum antibiotics. In this small study of 20 patients, they did ultrasound guided pleural biopsy and took about 6 to 8 biopsies, and they found that that increased microbiological yield. They also sent pleural fluid and blood. So they found in this study of small 20 patients, blood culture only provided a microbiological diagnosis in 10%, pleural fluid in 20%, and pleural biopsy increased it by 25% to 45%. This will hopefully help direct which antibiotic to give and potentially the duration of antibiotics as well. How about other studies in pleural infection? So we know that septations are important predictors of outcome. But how can we predict that? So there is a plasminogen activator inhibitor has been found to be independently associated with the presence of septations and septation severity, and it's thought to be the first biomarker which is independently associated with mortality. So in summary, chest drains are first-line treatment for all and hopefully will suffice with antibiotics in patients who are presenting in the early exudative phase of their pleural infection. Fibrinolytics would be effective if there's a loculated collection and may avoid surgery and reduce length of stay, and suitable in frail patients who are not suitable for more invasive treatments, but there is a cost. Bleeding risk we know is less than previously anticipated, but obviously there's the availability and administration. In the UK, we've had limited stocks of TPAA and have had to use other agents such as urokinase because it's been reserved for patients with strokes and myocardial infarction, for example. Thoracoscopy, I think the jury is still out, but offers a potential option early on if you have access to it in patients who, again, may not be suitable for surgery, and it can be physician-led. Surgery obviously is definitive treatment, may reduce length of stay, but obviously there's a risk of general anesthetic and the operative risks. So going back to William Osler's quote, empire needs a surgeon and 3 inches of cold steel instead of a physician. I suppose we're now beginning to appraise whether a surgeon really is useful early in pleural infection or not. And I think the randomized controlled trials, which are happening in the next year, a couple of years, will try and help answer that question. So what do I do? So when a patient presents with me, depending on the severity of the illness, I'll do an ultrasound, decide what stage their pleural infection is at. Probably I will insert a cell doing a chest drain, 12 to 18 French, and do thoracic ultrasound, and that will dictate my management. If it's heavily septated and they're young, I may consider early referral to thoracic surgery. But if not, then if they're frail and got comorbidities, I will use fibrinolytics first. It's important to address nutrition and see a dietitian. And depending on the scenario, we'll give antibiotics anywhere from 2 to 6 weeks. But ultimately, how you manage these patients depends on your local healthcare setting. There is an excellent ERS statement on the management of pleural infections by Ihab Bidawi, which I've not had time to go into, and I'd strongly encourage you to read this. This was published recently and it's in press, and answers a lot of questions on pleural infection based on the current evidence base. I would like to thank you for your attention. These are some nice pictures from colleagues who I've met at the RESPIRE 11 2019, and I look forward to visiting Sri Lanka again and meeting a lot of you in the near future. Thank you.
Thank you, Dr. Pancha, and thank you for your comprehensive talk as well as setting for the next lecture. So the next talk would by Dr. S. Handagala, who is a consultant thoracic surgeon from National Hospital of Respiratory Disease, Valisera, and he'll be talking to us on surgical management of pleural disease.
Still good morning, and first of all, I would like to thank the College of Pulmonologists, the President, the Council, and the Chair of Academics for inviting me to deliver this lecture. And from the inauguration, I know now previous speakers have eaten into my time. I would try to finish it in 15 minutes though. I met one of my colleagues who is a professor in neurology, and he was telling, unfortunately, it's unlike in your fields, our neurosurgeons, they don't listen to us, right? And I'm glad to, and that's a real good comment, because we do work in harmony, and when we start from the most senior chest physician up to the most junior one, we have good collaboration, and for the benefit of the patient safety, and it's a CPD process that we involve each other. I also attended the CPET workshop the other day, and we learn a lot, I mean, at this stage. Thank you very much, and it's a good comment from eminent professor in neurology that we work in harmony. So overview of my presentation is that I know I can't finish this in 15 to 20 minutes. So the topic is the surgery in pleural disease. I will just touch on certain areas and show the exotic stuff that we do. And having listened to previous speakers who are eminent, speakers from their specialty, although the field of thoracic surgery, I mean, all over the just physicians or all the physicians are eating into the surgical fields, but I know you are very good technically. I know from the chair of the academy, he is a pioneer in doing plural work, and even Dr. Ofla, and they do. But with our present, the waiting list and the limited resources, we really need that. And I encourage most of you, the junior pulmonologists, to do more and more plural work, because that amounts to about 50% of our workload as well. I believe it's so in your field as well, right? So the pleural conditions are diverse, and from inflammatory to miscellaneous condition. I'm not going to read out everything. So there are abnormalities in pleura or pleural cavity, the effusions, pneumothorax, and thickening nodules, foreign body, and then invasion of non-chest organs into the pleura, and there are some mimics of pleural condition. And the diagnosis could be clinical, imaging, or fluid analysis, blood test, biopsy, medical, thoracoscopy, or VATS. And then the treatment will depend on the diagnosis, the performance level of the patient, and availability of the facilities, and expertise of the team, and the patient's or family's wishes. And the options are diverse, again, from chest drains, pleural aspirations, to VATS or open surgery or other techniques. And if you consider about the future, there are advanced in the field like robotic surgery or fetal procedures. So with regard to effusions, there are exudative effusions and transudative effusions. I'm not going to go into detail of these because previous speakers have spoken. And with regard to pneumothorax also, this is bread and butter of both of us. So the simple or spontaneous pneumothorax, there are primary causes and secondary causes. Then traumatic, it could be penetrating, blunt or iatrogenic injury. Then there could be non-lung pathology causing pneumothorax like esophageal perforations. It could be iatrogenic or then spontaneous perforation of esophagus. And nowadays we get a lot of referrals with esophageal surgery, perforations by ENT surgeons, especially in the middle of the night. ENT trainees trying to retrieve, the accidentally swollen foreign bodies. They tear the esophagus and call us the next day morning. So that is the commonest cause of esophageal perforations, unfortunately. Then the pneumothorax could be the first episode or recurrent, and then partially treated, sometimes previous pneumothorax, previously treated ones. There are various scales of patients coming to us. And it could be in patients otherwise healthy or in patients with multiple comorbidities. So we have to cater our treatment depending on the patient. So this could be in ward setting or in an ICU or operating theater or in ventilated patients. So we have to cater our treatment according to where the patient is and what facilities we have. And there could be patients with continued aortic or sometimes with surgical emphysemas or mediastinal emphysemas. So, and previous 2 years we had in the era of COVID-19. So sometimes there were situations even in private hospital, I had to wear the PPEs and have a bath 3 times a day before going home, So that was very busy. We had to put tubes in that era. So I don't wish that era would come again. So these are some pictures of pneumothorax with bulla on the first picture on the left. And then the one on the right, you can see the there are some blebs on the apex of the lung, and even the lower picture you can see blebs. This is a video thoracoscopic. I know your view for medical thoracoscopy may not be this good, but we have better resolution, I believe. And with the present system of training, I think most trainees come at some stage for 2 weeks to Velisara, so they get a lot of exposure to this, and they will be more familiar with these pictures and setting. Pleural thickening nodules, again, the different pathologies. And these are some pleural thickenings. You will note some malignant diseases. And the foreign body is another thing that we encounter frequently. It could be firearm injury or missiles or from blast injuries, then migrated prosthetic material or sometimes broken tubes. Even some pigtail catheters have broken and pieces remain in the pleura. And then IC tubes, then cannulae. So the previous one was a picture of a sharpnel. And this is a patient who has had epilepsy before, and he has had a fracture of the humerus, and Steinman pin, we call the metal pin was there, and in one of the follow-up they noticed the one pin is missing to see that it lies in the right border of the heart, like. So this is known, you must have seen, noted in medical student era, even IUCDs in the uterus migrated even up to diaphragm without any symptoms. So this patient, accidentally detected because he get frequent falls because of the epilepsy. And we did the VATS. This was during my senior registrar period about 15 years ago, and we managed to remove it by VATS safely. And the size is about, say, 4 inches length. And this one was a patient from last year. You can see the date, first 26th of January. This boy had jumped onto the bed, and unfortunately, mother was sewing something with the needle and the thread. The needle had been on the bed, and poor child's, chest was injured. And he has noted actually, he was trying to pull the thread, and with that he must have pain, felt pain, and with one breathing attempt, it had gone into the chest. And I'll show you the picture. So we managed last week to do VATS surgery and remove the needle. You can see small bit of thread still there. It had gone into the pleura, not only pleura, it had gone into the lung also. So safely removed the needle. This is just a sewing needle. So these things can happen. If you have seen the film called, what do you call, what destination there are what is that? Final Destination film. I mean, anything can happen, It shows the ways people can die, in that film series, Final Destination. So things, unimaginable things can happen, I'll stop it. This was the needle, static picture. And presence of non-thoracic organs in the chest, could be omentum, bowel, or spleen, or stomach, or liver, or diaphragmatic hernia, or defects. Sometimes, with the radiology, you might miss these things. Because we are surgeons, we see these things. And our differential diagnosis is more diverse than yours because we see these things. And this is a picture of diaphragmatic hernia, big diaphragm. If you can see the CT report, I mean, half of the abdominal organs are in the chest. So including the spleen, everything. And there are certain mimics of the pleural disease, like infiltrating breast cancer, and then some neurogenic tumors. You may think as a pleural deposit, but just paraspinal tumors. Then expansile rib lesions. Then retrosternal goiters might have, gone into the chest. And then esophageal duplication cysts or pericardial cysts. Those are very frequent things that we note. This is a picture of retrosternal goiter just going into the superior mediastinum. And this is a picture of rib lesion, and it was a benign lesion we removed. But initial on the X-ray, if you see, that's shown as a pleural deposit. So this is a massive mediastinal tumor we operated. More than half of that right hemithorax is occupied, even crossing to the other side, pushing the mediastinum to left side. we did a clamshell incision, and that is what you do bilateral thoracotomies and connect in the center, and we removed, that was 1.8 kilograms. And unfortunately, this girl died 7 days later with the ventilator-associated pneumonia. It's a bit unfortunate, but blood loss was 200. We managed to remove the tumor carefully, but unfortunately, she was unfortunate to survive. What are the surgical treatment options from chest drains like conventionals and Seldinger drains, then blind drains, or ultrasound guided drains? So then, as previous speakers spoke, long-term pleural catheters come in, but if not for this, economic downturn, so we would have used those as well. Then the pleural vents, I have used, say, a couple of pleural vents in our patient. I'll show you a picture. And then medical thoracoscopy, I mean, if we don't, our medical thoracoscopy is broken, but we do sort of semi-VATS-like. We put the 5 millimeter thoracoscope, the VATS probe, and we do under local anesthesia and sedation. It's sort of a modified method. And by VATS, we use multifocal or uniportal nowadays. And we do various procedures like biopsy, pleurodesis, pleurectomies, and then decortications using VATS, and open thoracotomies, and even sternotomies. Sometimes for multiple blebs, we might do bilateral treatment using a sternotomy. Then pleural space reductions like by pleural tent or muscle flaps. And in desperate situation, we might do window thoracostomies, that is called creating a window in the chest wall to treat retractable empyemas. This is a pleural vent, some of you might not have seen, and this is a very good tool for pneumothorax. And we have used, I don't know, Dushant, you must have used this one. No? So it's about 40,000 rupees, but if you consider the hospital stay, especially in the private sector, you put a tube and wait for about, say, 3-4 days, and it will easily exceed the cost of this gadget. So you can even, if the educated person, we can send the patient even with this gadget. So these things are coming now. And the right-hand side pictures are pictures of pleuro disease. On this one, you can see on the X-ray how the pleural vent appears. And one of my patients who had, even after the pleural vent, he had a apical gap. This is a static gap that is a loculated site. We can call it a pneumothorax, but lung is not dropping anymore because it has pleurodis. So this is actually a Maldivian patient, and he comes to me every 6 months to get his visa extended, requesting a letter because he can't fly with this. So this is a picture of a pleurectomy that we commonly do. This is the most commonly done surgery because these patients can be sent to the ward straight away. So this is how we do. We catch the parietal pleura and peel the parietal pleura on the chest wall side, but not on the mediastinal aspect, not on the diaphragm. So we achieve pleurodissease on that aspect. But I have seen less than, say, 10, for last 15 years, less than 10 recurrences. That is, the recurrences occur mainly from the blebs on the medial side, like from the cardiac aspect and the diaphragm side. So those patients we resort to do again repeat VATS and do a talc pleurodissease. So this is a picture of VATS, how we do, and this is the uniportal one that we cut about 3 to 4 centimeter of cut, and we try to do everything using a single port. But this is sort of the style, but I don't know. I mean, as a surgeon, I prefer to do a safe thing. If I feel that I get more time or the patient's life is at risk, then I would put an extra port if necessary. But this is doable. So you utilize small incision, and we have to sort of be conscious about putting the instruments in the corner, middle, or the lower part. So with practice, so we can do. I know. I don't think there are any surgical trainings here. It's a matter of practice actually. So this is open surgery by thoracotomy. We are doing some lung surgery. This is the open thoracostomy that I mentioned, because at the end, if all other procedures, after exploring all other procedures, we might go for open thoracostomy. So we make a small incision. We have to remove small pieces of, ribs, two adjoining ribs about 2 to 3 centimeters, and invert the skin so that there is a wound. I mean, it's a iatrogenic fistula we create, a pleurocutaneous fistula. So we have to dress initially, but this is disfiguring. For young patients, we have to give ample time for them to bear the tube. They come in and out, with the tube. So if the patient eventually frustrated, staying in the hospital, having tubes for a long time, then they eventually like to have a thoracostomy, because with that they tend to get disfiguration, sort of scooping onto that side. But we have seen 2 patients on whom lung expanded slowly, infection settled, and spontaneously this thoracostomy healed. So that also we have seen rarely. And especially this is important when there is, intractable, we call fistulae. We call pleuropulmonary fistula. So when there is air leak, if the patient is not fit enough to operate, not fit to go for a pneumonectomy, then this is the only option. The patient will be living, but with deformity. So there are things, because we talk about transplant nowadays, there are pleural diseases coming in lung transplanted patients for these conditions. So sometimes we may be involved to operate to attend to these. And the future is the VATS advances to RATS called robotic assisted thoracoscopic surgery. But unfortunately in Sri Lanka, so we are trying to have even IC tubes nowadays, because there were times we cut holes in the tube that comes with the bottle and had to put for empyema, not for surgeries. And thanks to College of Surgeons and SLMA, we got some tubes. So I don't think we can think of robots at the moment. I know India there are centers, more than I think 10 centers where they have robots, our neighboring country. And the multiportal trending towards uniportal, as I mentioned, and diagnostic accuracy and 3D ultrasound has, prompted in developed countries, especially in America, to do fetal surgery. So this is some fetal procedure that they do. And with regard to my topic, the pleural disease, I told you pleural mimic is one diaphragmatic hernia. For congenital diaphragmatic hernia, CDH, they do fetoscopic, occlusion of the trachea. They put a balloon in the trachea so that they reduce, rate of lung collapse. So they have proven that the survival of the baby is more with occlusion of the trachea. They do fetoscopically. And then that's to treat fetal hydrothorax also, they have used thoracocentesis and transamniotic shunt placements. And this is the one I mentioned. And even CCAM, the congenital cystic adenomatous malformation, now there is a procedure called EXIT. That is ex utero intrapartum surgery. While the baby, they do a cesarean section, take the baby out, and do the surgery while connected with the umbilical cord, and then only proceed to delivery. They have proven their survival is much better than treating the CCAM after patient being in the ventilator for a long time. So those are things coming up, especially in centers in America, Philadelphia, Mayo Center, and then Cincinnati. Those hospitals, they are experts and they advertise well for these procedures. So this is how we worked in the COVID era. And thank you very much.
Thank you very much, Dr. Handagara. I think you kept time. Actually, we planned to give a little more time, and you finished on time. Now, these 4 lectures are open for questions. Can we connect it to those overseas speakers? Okay. Okay. I think Professor Anandan and Professor Roman and Dr. Fanchal, welcome to the Q&A session, and all 4 lectures are now open for questions. and all 4 speakers in presence. Yes, Dr. Amit, if I can do. Can you give a mic to him?
Thanks for excellent session to all our speakers and Anandan, Rakesh, Panchal. Well, nice to see you all. Both of you all, I think Rakesh and Anandan mentioned about trapped lung and the role of pleural manometry. What's the distinction between trapped lung and lung entrapment in terms of transudate and exudate, and what is the approach to managing these patients, and what is the role of pleural manometry? I don't know who would like to take that question.
I can give a stab at it.
Basically, when I'm asking the difference between a trapped lung and lung entrapment in terms of being a transudative effusion or exudative effusion, and the role of pleural manometry.
Yeah. So if you remember the slides that I showed, you know, and then in a trapped lung, essentially you get a transudate where the lung cannot re-expand. Whereas an entrapped lung usually involves an inflammatory process which prevents the lung from fully expanding. It tends to partially expand. So in pleural manometry, if you have a trapped lung, you get a rapid drop in your pleural change in your pleural pressures as you remove pleural fluid. Whereas in an entrapped lung, you get sort of a combination between a normal lung manometry where there's a gradual change in the pleural fluid as you drain out pleural fluid, and then at a certain point that there'll be a sharp drop off. So you can use pleural manometry to tell the difference between a trapped lung and an entrapped lung.
Thank you. In terms of pleural disease, a clinical pleural disease, does it make a difference with if a trapped lung and entrapment?
Well, the challenge with pleurodesis is you need to have the lung re-expand, and you need to have apposition with between the parietal and visceral pleura. So in a non-expandable lung, you're unlikely to have successful pleurodesis. So usually in both trapped and entrapped lungs, pleurodesis tends not to work.
Yeah. Please introduce yourself and direct the question to the particular speaker.
Yeah, my question is from Professor Ravi Panchal. This is regarding when you encounter empyema. So in our country, we encountered bacterially infected pleural empyema as well as TB empyema. So how do you, so in UK, you also have immigrant population, you also might encounter a TB empyema and a bacterial empyema. So how do you differentiate these between these two entities in the absence of a pleural biopsy? Because the diagnostic sensitivity of the pleural fluid TB cultures and PCR gene expert is quite low. And how do you differentiate between these two conditions in the absence of a pleural biopsy?
Hello, can you hear me?
Yeah.
My question is to Dr. Panchal. This is regarding the differentiation between the TB empyema and the bacterially infected pleural effusion. From the pleural fluid analysis in the absence of a pleural biopsy.
Can you hear me?
Yes, I can hear you.
So I work in Leicester in the UK, so we have a large immigrant population, see quite a lot of pleural TB. So in these patients, we'll probably opt for early thoracoscopy and pleural biopsy, but I know your question was directed to in the absence of a pleural biopsy. So Gene Expert is obviously validated for sputum, and we do it on bronchial washes, but we also do Gene Expert on pleural fluid. And I found that it does give a signal, and I'm writing something up about this. And I think it's helpful when patients may not be suitable for the invasive investigations, because we have had patients who've had positive Gene Expert, which has directed our treatment, particularly if they're more elderly or frail. But we probably would not treat these patients empirically. I mean, if it was a lymphocytic effusion, we would try and get some sort of pleural biopsy. If there is not just evidence, if a pleural biopsy is not possible thoracoscopically or surgically, we may look for alternative sites. So whether there's any lung parenchymal involvement, so we do a bronchial wash, or if there's any lymphadenopathy, try and get an EBUS biopsy. I think we probably wouldn't treat empirically here in the UK, but we have found that Gene Expert does seem to show a signal. I don't know if that sort of answers your question. I know Naj is on the call as well. I don't know if he can offer any further insight.
if I may comment on that, we found that the ratio of ADA to LDH quite useful in these patients. There is data on that, and so we have some data locally also, where in a frank empyema, the LDH to ADA, pleural fluid ADA ratio would be quite high in the range of 60s, and in a TB empyema, the LDH to ADA ratio would be around 16. This has been our experience also in a limited series that we have done.
Okay. We don't have access to ADA where I work, and I don't think it's widely practiced here in the UK. I don't know, Naj, if you use ADA, but we don't. We don't
Yeah,
tend to do that.
so Rakesh, we do have access, but it takes a few days, as you say. I agree with you. We tend to look for further microbiology, but we don't find it difficult to do a pleural biopsy. I mean, an image-guided pleural biopsy takes about the same time as a thoracentesis. So I'd encourage colleagues to just get a pleural biopsy done. Yep.
So my name is Dr. Handagala. I'm a thoracic surgeon. This question is to Dr. Anand, because as a surgeon, we get a lot of referrals from those who had pleural effusions for renal failure as well as hepatic failure. So asking for us to do pleuro disease. So in Sri Lanka, because we do have a lot of tuberculosis, usually is a consensus by the chest physicians that we need to exclude tuberculosis before treating the pleural effusion, because they are going to be on immunosuppressants after the transplant. So I don't know, do you like to comment on that? I don't know whether the TB prevalence in Singapore must be less than this. So that is a very big concern in our cases, because we should not just treat the pleural effusion, we have to exclude latent TB before letting them to do the transplant.
Yeah, but I'm not sure why we worry about latent TB in a patient with pleural effusion. I mean, usually latent TB, you know, we can use serum testing to do with a T-spot or quantiferin gold to identify latent TB if that needs to be treated. Yeah, so why would you get latent TB in a patient with pleural effusion?
Anand, you didn't get the point, because these patients eventually who are waiting for transplants, you know, post-transplants, they are going to be on immunosuppressants. So latent TB can become chronic TB, and they can develop tuberculosis, which could be devastating. So that is their worry, because we have to detect the latent TB at that point, and then only allow the patient to go for transplant. But once you have permanent TB, after the transplant, it's very difficult to treat because they are immunosuppressed. So that, I don't know whether you got the point.
Yeah, and again, you know, if we identify latent TB, we would, no, I agree with you. We would absolutely treat that if a patient is going to get significant immunosuppression. Is there anything else that you wanted to ask?
No, I mean, I just wanted to explore your practice in Singapore. You may be experiencing less TB patients there, I believe.
No, we do have quite a significant TB load in Singapore, and you know, it's not only our transplant patients. You know, we are using a lot of biological agents for a lot of autoimmune diseases these days. So we do screen our patients for latent TB, and we would aggressively treat them. The importance with latent TB, especially in a place where there's TB endemic, is actually to distinguish between latent TB and active TB, because clearly latent TB is a single drug treatment, whereas if you have pulmonary TB or active TB, you'll need to use multiple drugs. So before we give patients a latent TB treatment, offer latent TB treatment based on either tuberculin testing or serum testing, we would, you know, at least radiologically make sure that they don't have any evidence of active pulmonary TB. And even if patients who do have scars and so on, we tend to get induced sputums on these patients to make sure that, in the sputum, there is no TB culture, and also we also get a TB PCR done on the sputum specimens as well. So if the sputum is negative for PCR and TB cultures, then we will consider treating these patients for latent TB prior to immunosuppression.
Okay, thank you.
Yeah, just adding to the what Anand said, the unilateral is a pleural effusion, the bacterial empyema versus TB. Now the Now, although the gene expert is positivity is not that much, but 40% of the pleural fluid positive can be positive for a gene expert. I frequently do that because in my practice, I have found several positive cases by doing the gene expert because it's a 40%. It depends on the how reactive pleural effusion versus the TB empyema. TB empyema means it's a TB lesion inside and the infected material inside. Then you smear and the culture and the gene expert positivity is very high compared to reactive effusion. That's for this one. And another thing that Anand said, we get several referral from our GI and the renal colleagues from the CLCD and the CKD patient coming with a refractive unilateral pleural effusion. But I think Dr. Handagala was mentioned because the risk of tuberculosis in our country, and we are always having a doubt about the TB. I usually, after going through the basic investigation, including the pleural analysis, I usually do the medical thoracoscopy because then if you find some small lesion, maybe the early stage, we can diagnose, and because of the before we say completely none, and I usually prefer to have the unilateral pleural effusion, which is refractory. After the definitive treatment, go ahead and do the medical thoracoscopy, and to clear the all particular problems. We may find sometimes AV malformation inside, sometimes various vascular anomalies, and I used to do, I just want to ask Anand then, your experience on the medical thoracoscopy for this refractory pleural effusion after extensive basic biochemical and the other investigations.
Yeah, but again, we wouldn't tend to usually do medical thoracoscopy on patients who have, who are very transudative looking effusions, or even if they're borderline exudates. I mean, if they're clearly exudative effusions and they're undiagnosed, those patients are a good case, for us to go in and get pleural biopsies and to clarify what's happening. If they're clearly transudative effusions, we tend not to, and again. We will tend to go clinically. We will make sure the patient is not in heart failure. If we try and treat the underlying disease, we would of course send the biochemistry to make sure that there's no TB. If it's lymphocytic, we will consider sending an adenosine deaminase to clarify whether it's a reactive TB effusion. But no, if it's clearly transudative, we wouldn't usually go in and do a medical thoracoscopy.
Another question to all three speakers now. The TPA is limited in our practice. We commonly use the streptokinase as a fibrinolytics in our practice. I'm actually using last 20 years. I'm very happy with the streptokinase treatment for all this for fibrinolysis in the all chronic pleural effusion. And because we have a limited supply for TPA, particularly limited to the cardiology, and then the trial evidence mainly for the TPA and the combination. I just want to get all three speakers your experience on the streptokinase for fibrinolysis, as what we are doing for years now, and practically we are very happy with the outcome. Professor Rahman,
yes, sure. Yeah, no, of course. Yeah, we've heard that's a lot. A lot of people say streptokinase works. The problem is that it doesn't work, and there's a placebo-controlled trial, which is the largest ever randomized trial in pleural disease, 450 patients, placebo-controlled, double-blind, that shows that it doesn't work. Now, I think the reason that people believe it works is that we now know that if you give fibrinolytics, it causes pleural fluid leakage from the pleura. So as the physician at the bedside, one gives the drug and the next morning there is a huge amount of fluid in the bottle. And I think that surrogate is mistakenly taken as success. So no, I don't think it works because we have a very good randomized trial that shows it does not work. I think only TPA and DNase works, and we now have 2 randomized studies showing that fibrinolytics on their own without DNase does not work in pleural infection. In other diseases, septated malignant effusion or inflammatory effusion, I think it may well work, and we need to do some more studies, but that's my view.
Yeah, I have a question for Dr. Najib Rahman. My name is Madhushanga. I am a senior registrar in respiratory medicine. In day-to-day practice, we get a lot of pleural effusions where we do ultrasound guided aspiration. During the procedure, we tend to note there are some echogenic particles in the pleural fluid. Does this indicate any evidence of organization or granulation? If so, is it a contraindication to undergo a diagnostic pleural fluid aspirate? And one other thing is the echogenic swelling you mentioned, is it the same as echogenic particles? Thank you.
Yeah, thank you for the question. So I think they are in fact the same thing, echogenic swirling and echogenic particles. In answer to your question, is it a reason not to do a thoracentesis? Definitely not. You should definitely put a needle in there unless there's another contraindication. Some people believe that the appearance of the echogenic swirling means that it must be a hemothorax or an empyema. Actually, we and others have shown that it is somewhat predictive of exudate, but not 100% predictive. So it has a positive predictive value in the region of 80%, which means it's not 100%. So I think it's useful to see. I think if, for example, we were talking in the last question about a transudative effusion, if on a transudative effusion, you suddenly see lots of echogenic swirling, that does raise the suspicion, and I would definitely put a needle into such an effusion. It would be nice, wouldn't it, if it always showed hemothorax or empyema, but it doesn't, I'm afraid. You can have a free-flowing exudate, which is very echogenic as well.
So now we have come to the end of the session of this Pleural Disease Symposium 10. And once again, I want to thank all the 4 speakers, Dr. Anandam and Professor Najib, Dr. Rakesh and Dr. Handagala. And the number of questions we had, and I'm sure a lot of people are interested in asking some more questions. Due to the constraint of the time, I thought we will end up this session. Once again, thank you very much for everybody, including all of you all who have attended the session. And I would like to ask Professor Dushanta Madhakethara to give a token of appreciation to Dr. Handagala.